Hello and welcome to the Holding It Together podcast. I'm your host, Michael Macniak, and here we get real in our conversations about mental illness, caregiving, and the messy reality of keeping it all balanced. No sugarcoating, no clinical jargon, just real talk about the hospitalizations, medication battles, and the toll it takes on a home and all of those who live in it. This is for the parents, the siblings, the partners who are all doing the impossible every single day. Holding It Together is a home for the overthinkers, the multitaskers, and anyone who feels like they're just one spilled cup of coffee away from a meltdown. You can find us on YouTube at HITKINDA, that is Hit Kinda, and subscribe, like us, follow us, comment about us, vent to us, throw rocks, do whatever you need to do. Just do it today and try to follow us and like us and tell all your friends. Folks, I'm really excited today to bring you an old friend of mine who's been just an absolute superhero in the world of mental health and all different kinds of programs. I think she's initiated. I really think you're going to get a kick out of her. You'll see what I mean when I say that interviewing Colette Anderson is really easy, but she's going to talk to us today about trauma and the meaningful work that she's done around trauma and how it relates to mental illness in the family. So I hope you really enjoy today and take a lot of what Colette has to offer to us from all of her many years of experience. I'm very excited to be here with you again this month, and I'm very excited to have my real special guest, a friend and a mentor who I've known for, geez, believe it or not, Colette, it's been 25 years, something along those lines that we've known each other. It seems like a long time, and Colette Anderson is here to my left. I don't know which way you guys see her, but she's here to my left. Colette has been a leader, and it's the only way I could say it. She's been a master leader of the Department of Mental Health and Addiction Services in the state of Connecticut for over 30 years. She is respected beyond respected. She has just implemented so many strategies that have been adopted on a statewide level, and she's adapted and created so many programs that have really informed the way that people treat folks with mental illness, how systems are set up, and her fingernails or her fingerprints go far beyond just the state of Connecticut. She's got far-reaching influence, and I'm really proud to have her as a friend, and I'm really proud that I could bring her here today to have this discussion on a real important topic that I don't know that much about, and I never really thought too much about. So that's why I think it's really cool to have an expert like you, Colette, here to talk about trauma.
Thank you. Thank you.
And it's what's astounding to me is the number of people in this world who are impacted by trauma in and of itself. I believe the statistics say something like 55 to 90% of all of us have some kind of trauma in our history. Is that accurate?
Yeah, that would be accurate. Most of the fact finding that we're using to kind of assess groups as they think about how much trauma is in a group of people that are coming together is the ACEs study. And the ACEs study that was done by Kaiser Permanente was a world known study where they developed a questionnaire. And from this questionnaire, it's 10 questions, we were able to assess the level of trauma effects on people during their childhood. So from childhood to adulthood, you think back and you answer these 10 questions. And in an average group of professionals, if we're having a meeting and we're talking about ACEs, you get a range of people, but a large group of people who are in the behavioral health field have themselves suffered a variety of traumas, 4 or more in many cases. So when you look at this 1 to 10, very few fall at the very low end of having had no trauma experiences in their life. And the reason it's important to know that is that the healthcare professionals that are working with the folks that we love, they too have had these experiences. And so it's a very common thing. And this study was done in a predominantly white upper class individuals out in the California area. And so when you think about the neighborhoods that are more impoverished, the numbers are even higher. So it's a thing we do sometimes, where we actually have people answer the question, and we put it online, and everybody puts their score in, and you can just see from the group you're talking to how profoundly affected people's lives have been from traumas.
That's interesting.
And we're talking about, the types of questions it has to do with, has any of your parents been incarcerated? Was there violence in your home? Was there alcohol or substance abuse in your home? Did you ever witness one of your parents hitting the other? Some of those sorts of things that go on in everyday life. And when you add them up and they compound on top of each other, it causes that trauma reaction to the individual. And what we do know is that some individuals are more affected by those events than others because of the amount of things that happen to help them become resilient. So there's resiliency factors that people have, and the more resiliency factors that you have or that you acquire in your life help you overcome them, so that people are more productive and are living a better life.
Well, and I think that sort of goes to the point that I wanted to bring up. You brought up one of the points that I wanted to get to today, is in that because trauma is so prevalent in our society, as I said, 55 to 90% of us have experienced some kind of trauma. And my crummy math basically tells me that means that 9 to 15 million people in the country who have a form of mental illness have also some form of trauma. But one thing that you brought up that I did want to point out is that since all of us have some form of trauma, more than likely in our history, the folks who are working in the trenches with people with mental illnesses have also experienced trauma. And so you brought that up. But one thing I want to make clear, and this is one of the questions that I definitely wanted to get to with you, and we might as well just get to it right off the bat, is people with mental illness have not necessarily had trauma, and people that have trauma do not necessarily have mental illness, correct?
That is correct. What I think, my understanding as I think back, because, I started in the mental health field back in the 70s, kind of scary, but, we didn't understand the effect trauma could have on the life cycle of people back then. And so we focused on the diagnosis and the mental illness and the medications and the different treatment modalities. And it wasn't until, about 20, 25 years ago that people started to talk more about trauma, started to talk about the ACE study that had been done, long ago. But even though they had these phenomenal results, no one was using that to think about, how children's lives are affected by trauma and how that life trauma affects them as they become an adult. But now that we know more about that, more of the treatment that's out there for people with mental illness also has been designed to focus on treatment models for people who've had traumas. And so there's a lot of evidence-based group treatment models for people who are suffering from trauma. The other thing is that we have to treat everybody as though they may have trauma, because it's not just the people coming in for mental health or substance abuse services. It's the staff that are treating them, and it's the everyday person you pass in your life. So everybody you encounter, you go to the post office and you're interacting with the postman. You don't know what life experience that individual happened to have. And when they respond to you and you react, it may be coming from a place of trauma.
You mentioned a couple of examples that are, and I certainly will find this assessment, this ACEs assessment, and I will put it up as a resource for families who are here as in this group, so that they could take a look at it just out of curiosity and out of interest, because it could very well shed some light on, oh, that's why Jimmy acts this way, or that's why Susie responds to this in such a way. So when I think of trauma, my head instantly goes to, I got raped, I got mugged, I got beat up. But another thing that I think of that is very traumatic as well, and one thing that you and I worked so hard to stop, is the recidivistic decompensation of folks with mental illness and how they keep cycling through that. Because to me, that's a traumatic event every time they have to go through it. So what are some of the other events that may what is trauma? What's the...
So there's one of the things you just raised is the difference is between gender and trauma. So for women, they're mostly, the trauma that women experience is often perpetrated by someone they love. And so a lot of times it would be people who are having domestic violence, abuse within the home. It's usually someone who loves them that hurts them. The situation is usually different for men. And for men, it's community violence, it's war, and it happens to them from people they don't know. So women and men experience trauma differently, not all the time, but if you were to just look at the different types of trauma that people experience, there's more likely that a man was traumatized by a stranger and a woman was traumatized by someone who loved her. And so that's a big gender difference. And
That's
the
amazing.
response is different. So men who've been traumatized, often we see them as angry. Men go to anger management groups because they're angry, they're hostile, they're punching walls, they're, doing these behaviors. And women tend to internalize the hurt and the pain and are more likely to do self-destructive stuff. So some of the people that we have seen that are, burning themselves, cutting themselves, pulling out their hair, trying to mutilate their bodies, and some of those things that they're doing, they are trying to get back in touch with their with themselves, and they internalize the pain and they harm themselves. And so people's responses vary. And that's just if you were to just say black and white men and women, but there's the whole spectrum of gender that we're now starting to talk about as well, and how it affects different groups. And it does affect different people differently. So we have to be very aware that one person may come before you and because of their life experience present in one way, and another person could have had a similar trauma, but they may react in a very different way. And so how do we treat folks who have the variety of reactions, who are coming in for care? And if we're talking with families, there's intergenerational trauma that we can't leave out. So for
I want to get to something about that I read about too later on, because I read an interesting stat and I wanted you to comment on that. And you just reminded me, I have two friends that were in Vietnam at the same time. One of them deals with it by talking about it, sharing his experiences, and and telling these wonderful stories. And the other one deals with it by not dealing with it. And so I just think, as you said, we could have two of the very exact same experiences and manifest them very differently. But when we talk about people that are impacted, naturally all of us are somehow impacted by trauma. But what I also read is that a lot of the vulnerable populations are more inclined to be impacted by trauma. And you mentioned some of the socioeconomic factors in our cities.
Right. I mean, people who are in an impoverished environment are more likely to experience more trauma. Inability to get their basic needs met, such as food, housing, families that are living in cars or going into shelters, more likely to have some violence perpetrated towards their children in those settings. So, minority populations are at higher risk for being victimized by people in general. And so when we think about it, when we see these numbers about people from a white middle class scoring so high with these ACEs, when we look at these other populations, their scores are going to be even higher.
Right. And it's not necessarily, you use the term victimization. People can be victimized because they may be in a class that is poor, homeless, mentally ill, right? So that's an easy thing. But there's also experiential and situational things that some classes tend to see more often than not. Remember back in I think it was in the 90s when we had all the drive-by shootings and that phenomenon was going on. So those people who lived in those communities, the experience is very different, say, than me sitting here in Rhode Island right now, right?
Right. Exactly. And then there's the family piece that comes with you. So if you are a child whose family came through slavery, if you are a child whose family was a part of, what went on in Germany in concentration camps. So, you could be sitting with somebody whose grandparent was imprisoned in a concentration camp. And whatever happened, they survived, but they passed down some of what happened to them in their genes to their children, and then their children have children. And some of those uneasy feelings, we talk about there being a lot of our young adults right now having a lot of anxiety and depression, and what's that all about? And it may not be sometimes because that person personally went through, but their family may have, and it's been kind of carried down in terms of the culture and the internal DNA of that person as a survivor of their family having gone through some horrific stuff. And so that's another whole branch of trauma that people don't talk about or think about often, but lives on in families. And so as we think about that, what we're trying to do is help families understand what their family history was, where they came from, how that may have also played a part in who they have become, and how do we stop that and help the next generation to not have that angst in their body.
That is so amazing. That was exactly, you jumped all over my, you jumped on my question, so to speak. You stepped on me because my question was going to be about that. So now we've got victimization, we've got this experiential thing going on, we have situational, and now we have this whole nature and nurture argument. And what I read, the stat that I wanted you to comment on that you just did, was that studies are showing now that trauma can exist up to 2 generations after the actual event.
That's correct.
And that's what you just said, essentially.
Yeah. And there's more and more research being done on it. So we're getting more and more information. Recently had a presentation. I run a trauma and gender learning collaborative, and I had a woman come in to present on intergenerational trauma. There's people who are looking through all the literature on that topic and presenting more information. And in the work that I do around training organizations and doing systems change, I always think about, what's the most current things that we haven't talked about related to trauma. And intergenerational trauma is very big and needs more understanding, as well as the gender piece. And I think our society is more open to thinking about the spectrum of gender and how that plays an effect on a person in terms of where they're doing and what's going on. And, things that gone really well under the current administration. I think we've had a little bit of a backslide about how people think about people who are different in our society and how they are marginalized and how they are treated because of that. And so as we think about the trauma of being somebody who identifies as LGBTQ, and that's another hope.
Well, that's the first thing that jumped into my head too. You talked about acceptance, and then you talked about marginalization, and the first thing that jumps into my head is the LGBTQ group. I mean, if anybody's been marginalized, well, not only that group, but frankly, that's the reason that we're here, is because the marginalization of folks with mental illness in their families. And I as much as, yes, we understand the LGBTQ population, group, gang that out there has been marginalized. I still think that the last closeted secret in this country, at least, is the mental health secret that we don't talk about. And I mean, credit to the folks who have dealt with breast cancer. Credit to the folks who are on the front lines of the LGBTQ renaissance, if you will. I mean, even going back to what the folks have done with what we used to call mental retardation or developmental disabilities. I mean, we have all these great things. We've made a lot of strides, but there's still obviously some that need to be. But trauma manifests itself differently in different people. We talked about that, but some of the things that we may see in our families are things like, obviously, the first thing is post-traumatic stress disorder. It has trauma right in its name. Drug use, depression. Can you think? I'm sure there's.
Yeah, when I do some of my trainings, I have a page with a list of things, and it's columns long. So there's so many different things that it has an effect on. People who have eating disorders, people who are inflicting harm to themselves, people who are, isolating and not wanting to interact with other people. So it's the list is so long. And when I usually put it up and show it to people, because it's, I think, 3 columns, and I always ask the group, can somebody come up with other topics? Because I know it's not all inclusive. There's so many things that people don't realize are, ways that people are reacting to the trauma in their life and how that's described or seen by other people is usually viewed as the person being like non-compliant, non-conforming, not, getting in the mainstream of society, as opposed to the fact that those are adaptive reactions to something horrific in their life. And until we ask the question, what happened to you? What happened? And we very rarely ask what happened. Why are you here? What happened to you? And really listening and understanding where that person's coming from, as opposed to, a psychosocial assessment where you're asking everybody about every little thing in their life. But if why are you here in front of me today? What happened? Even people who are incarcerated, we think about that. If somebody had asked you why you're before me in this courtroom, might the whole picture of what happens afterwards been different? And people don't ask those questions. We're trying to get people to be more, let's put it right out there and ask people why they're in the situation they're in. Because if we give them time and we listen, we will learn a lot. The problem has been we haven't done that.
I just wrote something about the art of listening. We communication is two-way, and a whole bunch of it, probably 60-70% of communication is actually the listening part that we forget that, right? But I think that this isn't to say that you just use the example of being in a courtroom. We're not going to excuse your behavior, for instance, but at least now we understand why, maybe, and we could bring in different approaches to address, curb, change that behavior in the future. Is that accurate?
Right. Exactly.
Okay.
We showed a film. I had seen it out in California. It was called The If Project, and the If Project basically asked, if you were asked these questions at the point when you got into trouble, could your life have been so different? So what if we were to go into the women's prison in Connecticut and start to ask women these questions and let them journal about it and talk about it and really get in touch with what led them to be in that situation? Might it decrease recidivism so that when they come out, their lives are different? But if we just incarcerate them and not give them any tools to look at what these traumas were and try to understand them so that when they come out, their life is changed, we're just going to keep repeating the cycle. So we have to figure out methods to break the cycle.
And I mean, in your world, psychology world, social work world, it's really learning new coping skills, I assume. Is that right?
Absolutely. It's helping. It's coping skills. It's self-care. I mean, given what we're going through right now, as everybody is in their own homes thinking about what kind of self-care are people doing, is how do we calm ourselves? How to, when we're feeling anxious, what do we do? And what are healthy coping mechanisms? So you look at this list of behaviors, adaptive behaviors people have to deal with the trauma in their lives. And then you say, okay, how do you take that adaptive list that are more towards negative things that people are doing and flip it to the more positive things, and you give them a toolbox of tools, some very simple mindfulness exercises, an app they can put on their phone if they're having trouble sleeping. Instead of taking the sleeping pill, they put on the app and they listen to something that helps them to get to sleep without having to take a medication or to drink themselves to sleep. So how do you help build healthy coping mechanisms to adapt to what your life has gone through? And sometimes people aren't even aware of what they've been through as a child until, a later point in their life. We hear on TV, oh, how could they not remember that, they were, raped or molested? And, the body's an interesting thing. The body keeps the score, and the body is going to put us in touch with what's going on when we're ready to be able to handle it. And everybody's ready at their own pace. So you don't know when. I met a woman recently. She was in her 70s, and she did not recall something that happened in her childhood until like 10 years ago. She was in her 60s when all of a sudden she made the connections about why her life had ended up the way it was. And, for everybody, it's going to be different. So
yeah,
we
you
have
get
to
into
allow
the whole
them through
the subconscious and the ego and id protecting ourselves from ourselves and our own life experiences. It's fascinating stuff.
Yeah. Yeah, it is.
but one of the things that I think that, where you see the impact in families in particular is where the individual who has experienced a trauma may be showing signs of, well, trust issues. You're my caregiver, but I don't trust you. Or our family structure is really not comfortable for me, and I'm trying to tear it apart in some way because it's not comfortable. Or and one thing that I definitely want you to talk about.
Just on that point though, about it could be sometimes people who've been through trauma they've never had that normalcy. So when that normal phase comes and things are really going well, it scares the crap out of them. It's like, wow, when's the shoe gonna fall? This can't stay this way forever. So on some levels, they're testing to see if it's gonna break and fall apart. And so they may do things because it's really scary for it to feel like this, because they're not used to what we might consider normal, what we might consider a normal adult. Sorry, I just had a call pop through.
You totally blacked out. Yeah, well, you were just talking about how some people just living with normalcy sometimes, normalcy isn't comfortable for people.
Right. And what it is that's not what their life experience has been. So it feels uncomfortable and scary. And they don't know whether they can trust it. They don't know if it's going to go on. So sometimes they sabotage it because it's just not how they've always reacted. They've always been where as soon as things get good, they fall apart again, and then they have to pick up the pieces and start over again. It's very similar to intergenerational trauma. It's this angst that's in there that you think something bad's going to happen, and that when things are going well, it's scary. It's like,
when I ask family members about, when I do intake interviews with family members and hear their concerns about being a family member of a loved one with mental illness, one of the things they say very often is, I live my life waiting for the other shoe to drop, which is what one thing you just said, which causes so much stress and anxiety. And I want you to talk about this thing that I just read about called vicarious trauma. Now, I'm a parent of a 22-year-old kid that has schizophrenia. How is that impacting me and the rest of my family?
So vicarious trauma is the effect that dealing with all these people who have had trauma affects you. So when you are hearing and interviewing people and they're sharing very intimate things about their life, that has an effect on you, and it builds up in your system. And eventually, even though you may not have had trauma in your life, you are functioning as a person who's been traumatized because those repeated stories and taking them to heart, because we're human. So when we hear these horrific things that people go through and we're sitting there, I mean, and tears are running down our eyes because we're like, oh my God, that didn't happen to me, but that was just so horrible. And then the other thing clinical staff do is they repeat it to other people. So, so-and-so does an intake and they get this family history that is like, oh my God. So they go into the lunchroom and they're like, you're not going to believe what happened today and what I heard. So then they take that situation that they were affected and they tell it to another staff. And now two staff are affected by something that happened to a family over here. And so that's vicarious trauma. You're traumatized from hearing, and you could do that. That could happen through reading. That could happen through intake. That can happen to a family member who learns about trauma that other family members have had. So the other family members say, oh, Sally, she's a good listener, so I'm going to tell her, I finally realized something's going on. So the family member goes to this other person because they think that person seems stronger, but that other person now takes that burden.
Yeah, right. So my interpretation or definition of vicarious trauma was off, and the way you just explained it clarifies that. But what I also read is that trauma within a family, living with trauma, not only for the individual living with it, but the family living with it, it also actually causes changes in neurological behaviors as well as psychosocial behaviors.
That's correct. So it's kind of the fright and flight instinct. So when a child has repeated exposure to violence in the home, as one example, it's not like you go out and you have a car accident. When the accident happens, you slam into something, you get all emotional. You know that energy that happens when you even have a near accident, that angst, right?
Sure.
That's a hormonal thing that goes through your body. It shoots the adrenaline, the dopamine, all this stuff starts to happen to your brain. Well, imagine being a child in a house where every day when they go home from school, these things are happening. So they're always on heightened alert. And so that affects their neurological development because they don't know how to shut it off. They never shut it off. A good video, if you want to see Nadine Burke-Harris, she has a TED Talk, a 15-minute TED Talk that I use in my trauma trainings because she is a medical doctor. She's actually the Surgeon General of the state of California right now. We tried to get her to Connecticut, but once she got appointed that big job, it's a little harder to get her. I was trying to bring her here in October, but it doesn't look like that's going to happen because she'll say she could come, but in the last minute she could back out. Who wants to have an event where the
pretty important job, especially right now. There's a lot going on.
But she does a really good explanation of the medical science, and she talks about. She does a story about a bear in the woods. How a bear. You come face to face with a bear, and your heart starts pounding, and you can have two reactions, right? You're gonna either take on the bear or you're gonna run. So it's a fight or flight response that people have.
Yep.
Well, imagine if that fight or flight response in these children is turned on every day. What's the neurological damage to their body? And that's where I feel personally we see some of this teenage gun violence and stuff. It's people who never got what they needed to address some of this stuff that went on in their life, and they just don't know how to cope. And they go to this extreme to try to say, I need some help here. Something's not right. Because they never can shut it off.
That's interesting in that we talk about just the chemical makeup of our bodies and how it can create, I guess, in our own makeup, our own science creates somewhat traumatic events for us through this fight or flight response. But I'm also very concerned for a lot of family members who are raising children who are normal, that don't have a mental illness, and right next door to the brother or sister who's basically turning this family over because their mental illness is, running through its course, and what those brothers and sisters in the house are experiencing too. And as you're saying, that has to be traumatic for them as well.
Oh, it is. And especially, what immediately popped into mind is the amount of deaths this generation of young adults is having from the opioid epidemic. And, we're losing a lot of our young adults, and their siblings are watching their siblings die. And they're feeling responsible because they knew something was wrong and they couldn't do anything about it. And there's a lot of family guilt, both from the parents, the siblings, all saying, what could I have done differently? And then once these young adults get these opioids into their system, and it could be a real innocent. The person played basketball, had an ACL injury, doctor puts them on an opioid when people were pretty much saying, oh, you can't get addicted to opioids. Next thing you know, the whole family is in this, drug addiction piece with this child who could ultimately, very high chances that child could die. And then, so they're dealing with that day in and day out and feeling some sense of responsibility and wanting to save that person from a horrible, horrible death. And so, the whole family's reaction to it, and the siblings, the whole family structure is going to be affected forever as a result of the horrific possible death of a loved one.
Of course. Yeah. And we go down the whole addiction road and what that does to a family as well. But, one of the things that I wanted to touch on is that the understanding for these families, first of all, we have trauma. To understand that there was trauma is the first step. Secondly, if we have a mental illness in our family, the concept of having mental illness, again, for the individual and for the family, what I read is a profound feeling of loss. There is a profound loss. And that in and of itself can be characterized as a trauma. And I guess I'm leading you down this road because I know you did so much work, and I've done it with you, with you and Roger Fallett and that team around creating a system of care that is very trauma informed, and how we change the culture of an entire system. So one of the things that I really wanted to hear your thoughts on was, how do we change the culture within our family to say, hey, we have a person with mental illness or addiction, for instance, in our family. Bam, there's a big sense of loss there. But what do I do next? How do we pick this family up by its bootstraps and move ourselves in the right direction, or never overcoming the trauma, but coping with it?
Yeah, I don't necessarily feel like I'm an expert in that area, but I would say that in the work that I'm doing with the Department of Children and Youth Services right now, there are a couple of very good family treatment models that the state of Connecticut is bringing in. So we're just getting more involved in trying to understand what some of these evidence-based models are out there to help the families in these situations. But I don't feel I'm an expert to be able to talk about them yet at this point. I'll learn more as we're doing more with them.
Well, but I think your expertise and especially your knowledge can help families to understand that if we think of mental illness in our family as a loss, or we think of trauma that occurred in our family as something that took away a little chunk of us, right?
Right.
And we accept that as normal. There's normal loss in the human condition. I would suspect that through the clinical aspect of treatment, we can learn to adapt to that loss, and we could grieve the loss, accept the loss, and then move on. Is that
that's where I was going to go, the grieving process. So it's similar to the grieving process that's out there, and looking at the principles of grieving and the stages of grief. You know, there's a lot of material out there right now because there's been so much death. We did a training yesterday that we recorded, and we had over 100 people on this line, and the topic was grief, and how are people grieving, and helping these families to grieve not the death of a child or a loved one, but the vision they had, or the view of what they thought that person could become, is what they're grieving. They're grieving that they thought this child would be here, and really the child's over here now, and what is that doing to what their expectations and the loss of what they thought their child could become. That's the hard thing that the families are struggling with. And it is the stages of grief, and looking at the stages of grief and realizing that everybody moves through the stages of grief differently and at their own pace. And you can have two parents, and one could be at a very different stage than the other, and that causes conflict within the home. So if you look at the stages of grief and you say, oh yeah, I'm over here, and she's over here, or, you know, and we can move around. We can move around within the stages of grief, and we're not always going to be in sync with the household. So we could be at different points. And if you have adolescent children who are going through it with you, they're at different points, and they are functioning at one level one day and at another level another day. And that system is together, but they're always at different places. And now how do you keep some cohesion in that household where people are grieving something that they thought would happen?
And the interesting thing about that is, not only may people be in different places at different times, but again, getting back to the strength of the family or the weakness of the family, and the structure that could tear apart is important. Yeah. And I think that it's important to say here that this is in no way meant to be a doom or gloom discussion. This is what I really wanted Colette and I to have this conversation with. The reason I wanted to have this conversation with Colette is because I want people out there to be aware of trauma. I want people to be aware that they are going through grief. And Colette just perfectly right there.
And the other good thing on the website of the Connecticut Women's Consortium is our Trauma Matters newsletter. So for over 20 years, we've been doing a quarterly publication, and those newsletters have all kinds of information. And we had a student categorize them so someone can go on the site and say, I'm particularly interested in family and trauma, or trauma and drug addiction, or trauma. And then we did one whole issue on trauma and veterans. I mean, so you could pull up some of those articles. We do these Ask the Expert, and we interview experts, and we have some podcasts of some of these people who we've interviewed around the country, nationally known experts on trauma.
And that's all at the womensconsortium.com website. Yep. Yeah. Okay. So I'll definitely give that out for sure. So just in sort of synopsizing the impact of let's say synopsizing in closing up the discussion about the impact that trauma has not only on folks struggling with mental illness, but also their families that are also dealing with the person that's dealing with the mental illness. What would you say is their best course of action?
For me, I think, you bringing out the information is really important for families, and for families to feel like they can ask the questions, look at some of the resources, and then seek advice about how to implement, if they can't do it on their own, people who can help them within their own family structure. Because when you're in the midst of it, it's sometimes you lose track, you lose hope, and by having somebody who's maybe more experienced working with the families, trying to help them stay on track so they don't lose hope, and so that they are able to see sometimes I use the phrase baby steps. Sometimes you're taking baby steps towards improvements, and when you're in the midst of it, you don't even notice the changes because you're so entrenched in it. And to really try to give these families hope that there are things that are changing for the better, but you may not always be aware of it, and helping them to notice it, because as professionals, sometimes we're able to see that before the families even see it.
Yeah.
Because they're so in it. They're so in it
Right.
every day and every night, that they may not notice that they are making some baby steps towards progress to becoming more resilient, to becoming better able to accept the fact that their loved one's life may not be what they wanted, but how do they live with who this young adult or who this child becomes in the midst of everything that the whole family has gone through.
That's good stuff. Colette, thanks for doing this for me. Thanks for being
no problem.
All this community, and thanks for the work you continue to do in the service of others for I mean, you must have started when you were 10, but
I had to
40 years
now.
I
35 years with the Department of Mental Health and Addiction Services, and I just had my 8th year anniversary at the consortium. Just keeping at it. And I thought by staying home, I might just want to stay home. But, what I realized is I got to give up some other stuff because I'm not ready to give up the work. I really do really enjoy what I do.
We're all really lucky to have you. That's for sure. I've been saying that for the 25 years I've known you. So thanks.
Yeah.
Well, this has been an incredibly grounding conversation. We often think of trauma as a single explosive event, but as Colette highlighted today, it's frequently the quiet, persistent weight of our histories, both our personal history and systemic history, that wind up shaping how we move through the world, right? We can't ignore the data that shows how trauma is distributed in this world. And acknowledging these numbers isn't about labeling certain communities or certain people. It's about recognizing that the deck is stacked, and that our care systems have to be designed to unstack it. As you head back into your week, I want to leave you with Colette's challenge. What question can you ask differently this week? Whether it be to a coworker, to a child, or even to yourself looking in the mirror, try replacing the why with a how or even a what. If this conversation shifted your perspective, please share it with at least one other person who might, need to hear that their survival strategies are valid. Subscribe for more episodes where we replace judgment with curiosity, and leave us a review to let us know which baby step of resilience you're tracking this week. Yeah, the deck is stacked, but who says that we have to play by their rules? I'm Michael Macniak, and this is the Holding It Together Kinda podcast.